welcome to today's informational call, SingleEntry Models for Improved Access to Care. Today we're going to be looking at a wait time reduction strategy that can reduce wait times, prioritize allocation of resources, and increase transparency by merging multiple wait lists into a single queue. As you heard, I'm Stephen Samus, Vice President of Programs here at CFHI. I'm pleased to be your host for today's call. And today we're joined by over 50 organizations from across the country, so thank you for joining us today. As I introduce our speaker for this session, could you please each take a moment to introduce yourselves in the chat box, who you are, where you're from, as well as any questions you may have already at the outset as we get going on the call today. Joining us today is Dr. Tom Noseworthy, who is Professor of Health Policy and Management in the Department of Community Health Services at the University of Calgary. He's a nationally recognized physician, researcher, policymaker, and healthcare leader. In May of 2011, Dr. Noseworthy joined Alberta Health Services as a special advisor to the Executive Vice President of Strategy and Performance. And from 2012 to 2015, he was the Associate Chief Medical Officer for Alberta's Strategic Clinical Networks. Dr. Noseworthy has received many accolades throughout his career, including being named one of Alberta's top 100 physicians of the century, and by being appointed by the Governor-General as a member of the Order of Canada for his contributions to health policy and medicine. We also have our producers here in Ottawa, Sheena Powell and Kelly Ripley, operating behind the scenes. In today's session, we're going to start with an introduction to single-entry models, or SEMs, and try to better understand the basic principles and specific features that contribute to the successful implementation of SEMs. We'll then drill into some case examples of health organizations that have successfully established an SEM and share best practices and challenges related to implementing these. Just to take a moment for those of you who don't know us, to introduce you to CFHI. We're an independent, not-for-profit organization funded by the federal government, dedicated to accelerating healthcare improvement for Canadians, with a mission really to work with healthcare delivery organizations across the country to try to encourage innovative new ways of working in healthcare and the spread of innovative ways of working across our country. So why are we focusing today on improving access and reducing wait times? Waiting for treatments has become a defining characteristic, unfortunately, of Canadian healthcare. Waiting too long for care is one of the most significant barriers to accessing health services for Canadians. And on a worldwide lens, or at least in the developing countries, compared to 11 OECD countries, Canada ranked last in timeliness of care and second last for overall efficiency. For medically necessary surgery or other therapeutic treatment, wait times have increased significantly from 1993 to 2014. In fact, the median wait time now for a medically necessary procedure in Canada is 18.2 weeks. And it's estimated that across the 10 provinces, the total number of procedures for which people were waiting in 2014 was over 930,000 Canadians. Evidence also indicates that wait times for medically necessary treatments are not harmless inconveniences. Wait times have serious consequences on both the quality of life and health outcomes for patients. As a result, patients report increased pain, suffering, and distress. In certain instances, wait times can transform potentially reversible illnesses or injuries into chronic conditions or even permanent disabilities. So long wait times are also economically costly to patients, families, and the country as a whole. And this is done through lost productivity, lost earned income, and lost tax revenues for governments. So what's the best way to improve access and timeliness of care for patients? Many believe that single-entry models are a promising strategy. As with any intervention introduced into a complex system like healthcare, implementing a SEM requires thoughtful design, implementation, and change management, including the consideration of the impact of this for patients, providers, and the system at large. And so today, Dr. Noseworthy will provide an introduction to single-entry models as one wait time management strategy and also for improving patient flow. We'll also hear a couple of specific examples of SEM systems that have been implemented in both Canadian and international contexts and discuss some of the successes and challenges associated with the adoption of SEMs. Dr. Noseworthy will also share his team's development of a toolkit for implementing SEMs based on the proceedings and content from a recent Canadian symposium on SEMs that he organized. It's now my pleasure to turn the presentation over to Dr. Noseworthy.
Good morning if you're in the West. Good afternoon if you're in the East. It's my pleasure to be with you today and to offer this webinar on SingleEntry Models. First of all, our team, in many and differing configurations, our group has been together since 1999, at first as known as the Western Canada Waiting List Project, and later funded by Alberta Innovates Health Solutions, and currently as a CIHR emerging team, in this case focused on total joint replacement and timely treatment for it. As you can see in this slide, we have a wonderful group of investigators, and a particular note to two graduate students that have worked quite a bit on a SingleEntry Model component of our research, that being Zahid Damani, currently doing a PhD that focuses on the Winnipeg Regional Health Authority's implementation of a SingleEntry Model for joint replacement, and Elena Lopatina, who has done a substantial body of work and was recently central to the National Symposium, from which will come, I believe, useful value to others that are interested at a provincial level in implementing SingleEntry models, and much of that work will be completed in this next few weeks. And finally, a special thanks to Winnipeg Regional Health Authority giving us the opportunity to work with them and both Manitoba Health and the Health Authority to study their implementation of a model and follow it up. By way of outline, I'd like to go back to the basics and just remind ourselves about the issues associated with access, and Stephen Sanders mentioned some of them. Do a quick review on what I'm actually talking about when I say the word SingleEntry Model, fly past a few international and national examples, and then focus in on the factors that are important if you're going to do this, and perhaps some thoughts as to the consequences should you proceed. And I do understand that there are people on telephone today that have had substantial experience with SingleEntry models, more than I have, and know about them in more and differing ways in all potential, and we'd be really happy to hear from you. Certainly our recent national symposium in mid-April, we had representatives from all provinces, and it was a very fruitful exchange, and there's varying interest in this subject of SingleEntry models, various experiences, and indeed some very well-developed and long-standing examples from which we could learn a great deal. So we'll end off then perhaps on a little advice if you're going to proceed. Why is this not a Canadian hospital here? I show this slide to my graduate students all the time. It's simply because there's no patients waiting in those corridors, and generally speaking, I'm afraid, we do not do well in international and Commonwealth country comparisons, OECD comparisons, and what have you. We are using our emergency departments as a gateway to the healthcare system for a variety of differing reasons, and as a consequence, use of corridors and off-service delivery is commonplace, as all of you on this phone well know. I think it's important to remind ourselves that access is critical. Obviously, if you can't get into a healthcare system, it's critically important. But it also is only one aspect of the many dimensions of quality. And here's the quality matrix that we use in Alberta with the 6 dimensions, a derivative of Institute of Medicine's definition of quality. And we're talking here about access specifically and getting into the system today. But frankly, we could equally as well on any of these webinars dwell on any of these actual elements, where if you look to the left side of that diagram and you were to focus on efficiency, safety, and improvements in appropriateness, one could reasonably imagine that there would be an ability to transfer resources into the other side of the queue, improving access, perhaps acceptability and effectiveness. Just to put my particular talk today in context, I'm not talking about access to emergency departments, even though that's a vexing symptom of the Canadian system, because that's often where people stack up for acute or more urgent circumstances. I am today largely referring to scheduled services, those things for which individuals go on usually a schedule of waiting or a waiting list that are not emergent, not a threat to life or limb, although many people on waiting lists for scheduled services, of course, have varying degrees of urgency of their problem. And to say that they're not emergent does not mean that they're not urgent and needing care in a rapid fashion. Dr. Sam's comment on a few of these things on his nicer cartoon slide than mine, but just let's remind ourselves that I think that generally speaking, none of us like waiting for much of anything. And one might reasonably assume that perhaps many of the technologies and changes in our larger culture are reducing perhaps our patience for any type of waiting for any type of service provision. But that issue aside, there are consequences when what you are waiting for is a clinical service of some form, assuming that you needed that clinical service in the first place. But first and foremost of this, there's a growing number of things for which it's important that we know when to intervene and how. The therapeutic window of opportunity, perhaps we might call that, a time when clinicians know that if there's a therapy of value, whether it's a disease-remittive therapy or otherwise, that there's a time and place to do it. And an unnecessary delay would reduce the potential for that therapy to make a big difference. Similarly so, forgetting the therapy, the clinical condition itself marches on with time. And while certain things are self-limiting and get better, many of the things for which people end up on scheduled lists are conditions which over the course of time would naturally tend to deteriorate, whether it's cataract and then eventually you lose visual function to the point you fall downstairs, or you have a motor vehicle crash, whether it's a knee joint that gives out so eventually one is not able to undertake any function at all. The clinical condition often deteriorates with time, and the longer you wait, the worse potentially it is, regardless of that therapeutic window of opportunity. Then for anybody, everybody, and everybody on this call, you know as well as I do, waiting causes anxiety, particularly if you're doing it in the face of an uncertainty, particularly if you feel any level of threat to life and limb as a consequence. Imagine a middle-aged lady who, because of the consequences of a dimmer light in her bathroom this morning, notes a shadow during what wasn't going to be a breast self-examination, turns out to be, and she makes a determination that there may be a mass or a lump present. Regardless of whether there is or is not and what that might represent, immediately there's a trajectory of anxiety, and regardless of what one waits for, over the course of time, there are consequences in broader and social behavioral impact that it has on individuals. And of course, that may reach the point where individuals lose their definition and their role in life, whatever that might be, including, in this case, loss of employment or serious impact to it. All of which, in the larger case, as one gets to the systems level, really, waiting does undermine public confidence in our system. It has always been referred to and still is the Achilles heel of the Canadian healthcare system, without doubt. And then, of course, that brings in the politics, particularly in our tax-funded system. Waiting times, waiting lists are very political, although, quite frankly, the political response to the long waits that we've had in Canada is somewhat less than enthusiastic, whether one thinks about it federally or otherwise. And yet, at differing times, depending perhaps where we are in the electoral cycle or who has waited for what that's drawn most noise, waiting lists can have very political consequences, as you know. To move on, this is a simple cartoon that I use for my graduate students, and it's about kind of the balance that I see in healthcare systems broadly on a global level, that who is into your system, what's the level of inclusion, or in our case, universality. What one gets at 12 o'clock in the diagram is, what's the bundle of services included in the service provision that is insured. And how do you get in? What's the mechanism of access? So this is just a simple attempt to say, here's a system where imagine everybody is in universally to the left, and they have a standard basket, a comprehensive basket of services, what one gets, and they get in quite easily with access because of the system imbalance. Slip to Canada, where we have universality, as indeed other countries do too, but the challenge in a universal healthcare system with all-inclusiveness is to how to get people in a timely fashion, which is not the case if we switch to this situation where I want to get in right away, and one way to do that is to, in fact, limit inclusion. And one might imagine that former diagram with universality and limited access is representative of Canada, and this one, at least in part, timely access with limited inclusion might be more representative of the United States. So universality does indeed challenge inclusiveness, not inclusiveness, I mean access, because inclusiveness is part of the universality. And indeed, some places have done quite a bit better in the face of universal systems than have Canada, and I would cite certainly the UK, Scandinavian countries as cases in point. If we look at our fleet of tools and strategies, approaches to dealing with waiting time management, thinking very broadly here, you have things that you can do to supply side, manipulating that in many different ways, usually by augmenting it as standard practice. There's demand side management of various sorts. Let's increase the appropriateness of care and reduce the inappropriate care by way of example. Or let's go more upstream and reduce demand on knee replacement by reducing obesity, by dealing with anterior cruciate ligament injuries in young soccer girls, as an example. So demand side management, we'll leave that out for the day. It's a talk in itself. And then the mechanisms that are available to us with simulation modeling, operations research, and whatnot of supply and demand balance, again, we'll not deal with that today. Let's just focus in on supply side management and specifically one aspect of it, of supply side management. And in that case, we're talking about single entry models. Now, priority setting tools, that would be using some form of standard metric that once patients arrive and you're beginning to supply the service, that you apply a standard, let's say, urgency rating tool, a priority setting tool, which acts to not speed up the lineup, but to change the order of it such that those with the highest level of priority are serviced faster than those with a lower level of priority, depending on what your priority setting tool measures. And then, of course, very popular in Europe and Scandinavian countries, waiting time care guarantees, again, an entire new talk unto itself, which has both supply and demand side influence. But we'll talk about today one aspect of supply side management, and we'll call that, for purposes of discussion, single entry models. And this cartoon shows the standard idea if you have, multiple lines and multiple, in this case, tellers, I guess is a bank analogy, versus one line and 10 tellers. So you can see roughly, it's been commonplace in banks, airline industry or what have you, to have a model that looks more like the one on the left than the one on the right. So when you look at the individual waiting list approach, now imagine you're one of those arrows going down through each of those lineups. You're the subject of any delay in that lineup, any delay, so that a delay as you proceed through that single lineup is experienced by everyone else in that lineup until that delay is cleared. You can't flip to another lineup, by way of example, and use up that quote-unquote dead time, because there may be another teller that might be otherwise available, and you can get serviced faster, which is generally the idea that there's variation, of course, in the service time in each lineup, no matter what type of queue in whatever industry it is. And if you delay, and you're in a group of single lineups, a delay in one transaction results in a delay in all transactions subsequently in that lineup if there's no crossover between them. This, however, is what happens when you put it together and consolidate the lineups. And as I've already said, what you're really doing here is you're summating the lost time and, in essence, distributing it across all lineups. And as a consequence, the flow-through lineups, all other things being equal, the flow-through lineups is faster, and generally the waiting time is shorter. And that's why we seem to have gone that way now in multiple and differing industries, and for good reasons. So I don't know if this is going to work. I took a chance in putting it together. It's not mine anyway. A wonderful graduate student did it for me. But this is the traditional system where a person has to go through versus a central intake model where the individuals now start moving through. I don't know if this is going to work. We'll see. But the mathematics, I gather, is such that when they flip through a single entry model like that, that you can see to the right-hand diagram that you get service faster, shorter waiting time. What do we know from the other industries? Where does this become pretty commonplace? We certainly do know, because it spreads the slack time, as I've already said, in the system, that it can improve the flow, and therefore the throughput if you increase the flow. And flow is the fundamental issue often in hospital-based scheduled services and access. It certainly does reduce average waiting time, but be careful here, because I need to sort of say all other things being equal, if the spigot opens up on the demand side, and as a consequence of improving flow through the system, more and more cases become available, then the average waiting time indeed might not go down. We've seen that in lots of different cases. This goes back to an old paradox that is been known since the 18th century, that if you do improve the efficiency of a goods moving through the system, you will increase its consumption, shown by people in the 1750s, Jevons Paradox, to simply say that, if you improve the efficiency of coal distribution, you will increase the consumption of coal. Not exactly rocket science, but it's true. And almost every time that we manipulate the service delivery side of the healthcare system and increase the flow, we don't get right away, sometimes we don't get at all, the average reduction in waiting times. And you will often see an increase in demand as a consequence. And we've seen that across lots of different types of service provisions. And of course, whichever industry, putting in a single entry model has consequences. Imagine when the banks did that. Imagine how we all had to get used to the ATMs, and the importance of which lineup you get, the one with or without the bag drop-off at the airport, and how annoyed you get if you're in the right lineup and no one else isn't. There's consequences for single entry models, and I think those are particularly relevant to bear in mind as we now move into thinking about them in relationship to health care. So what am I actually talking about? Halfway through, perhaps a definition might be worthwhile at this stage, admittedly, but you see, the problem is we don't have a universal understanding of what the definition of a single entry model is. Here's generic waiting lists for both initial outpatient appointments and subsequent surgeries, one publication, and is that a single entry model? Central access and triage, Alison Beichel's work, is that a single entry model? Or is a single point of entry intake service, is that a single entry model? What is in that so-called menu? And here's our sense, our group's thinking of it. It's a single point of entry to the system for whatever the service is. It's kind of a single wicket in a physical sense. It's the department or the desk through which things flow. That's the one of the elements. But it also has to do with the pooling of the referrals that are coming into that point of service. And indeed, it may or may not have something to do that when those referrals all come into that single point, there may be something done with those that makes a determination using some sort of standardization and priority setting tool of the degree of urgency. So there may be a triage at that single point of entry where the pool referrals come in. But the trick is, on the other side of the wicket, is service provision, is the delivery of whatever that service is, whether it's a surgical services, a medical consultation, a diagnostic test, or what have you. pooled service provision. In other words, you get the next teller. You don't pick the teller. You're not in a specific lineup. So it's some composite of these things, a single point at which people come into the system, with pooling of all of the demand load that comes into that point, with or without some transformation of the demand load to rank it in some mechanism using the standard measure. But the key is the pooled service provision, and yet there's no universal definition. And when you start looking at the literature for single entry models, you find it's not even necessarily even the standard term, because it would appear to our group, at least, certainly in New Zealand, and certainly through the OECD countries with whom we've had interaction through Dr. Siciliani, we would perhaps go so far as to say the single entry model term is not used because it's become standard practice in many of those countries. It more commonly might be perhaps seen or referred to in literature as pooling as opposed to single entry model. Looking at more recent literature then, and just studies that would seem to speak to this issue, the majority of them seem to include all three elements. There is a point of entry, there's pooled service provision after that point of entry, and there's some triage mechanism. Most of the limited number of studies that are out there would appear to employ all three, but some not as you see in the other inclusions in that slide. We are not completed yet, but Zaid Damani, who is now coming up to completing his PhD, is putting the finishing touches to help with help from Dr. Spady on the systematic review for single entry models, pool lists, and I guess I was surprised given the degree to which this perhaps could be seen as standard practice in many areas of service in other parts of the world. Pretty scant body of literature actually dealing with this, limited in scope, not well necessarily evaluated, and as in many of these sorts of small examples, one has to be cautious about the degree of generalizability to other places. Weak study designs, often no comparisons, or whether it's pre-post or otherwise, and really lacking in serious attempt to look at what happened, whether we were expecting it or not, anticipated or unanticipated consequences. And so the systematic review that we're doing at this point in time by no means is finished, and I can only simply say to you that there's certainly examples of single entry models, perhaps best described in gray literature and government documents than in peer-reviewed literature, but they're being implemented and they're in common use in many parts of the world. And Canada has some cases in point, which I'll mention in just a moment. As I say, they're common practice. Whatever definition one uses, and whatever elements within the buffet of single entry models that one might wish to choose, it always is irreducibly related to some form of pooling of the service delivery, whether that service delivery is by a group of orthopedic surgeons, joint replacement, or otherwise, that it's the next available surgeon or next available person for delivery that is captured in the single entry model. And as you can see, they've been implemented in a number of different clinical areas, perhaps most notably in Canada, in cardiac services in Ontario and in other provinces, and they've been in use certainly, for in the order of 15 years. This is an interesting slide that came to me by circuitously, and I recognize a thoracic surgeon of some note in this area in the UK, Richard Stein. And this is looking at his own referral group and consultants. And while it's a bit busy, it simply shows three phases, and just perhaps look at it that way. To the left, that blue arrow shows the phase when was referred to the consultant of your choice. Then they implemented a prioritization system, a standard measure of deciding the degree of urgency. And you can see not very much happened here, because remember, the waiting time shouldn't normally go down. by introducing prioritization, except for those people that are of the highest level of urgency, because they shoot to the front of the line. But if everybody goes to the front of the line, there are people of lesser urgency to go to the back of the line. So prioritization, in and of itself, while I think it's a good idea to get the order of the lineup correct, doesn't necessarily in any way speed the lineup or reduce the waiting time. But look what happened when they pooled appointments. There is a reduction, not only in the cyclic nature of the graphics, but also there's a mean reduction in the number of days that patients waited after Dr. Stein's work. This was chemotherapy for pulmonary malignancy. From an international perspective, at the conference of just a couple of weeks ago that we held in Ottawa, we had perspectives from New Zealand and from the OECD, and I suppose it would be simply to say that even in the lead-up to try to garner the speakers, and we asked for who are the experts in these areas, I wouldn't trivialize it in the least by simply saying that pooling of service delivery was reasonably standard practice in such a way that people question why we were interested in it, and perhaps why we weren't doing it already. But the more that they understood our system, understood our intent, but that practically some of the things that we might need to pay attention to if we were to proceed in that direction. And I think that the work now in Winnipeg that our group is doing will shed a brighter light in the peer-reviewed literature on what is the real attributable benefit and consequences when we do have single-entry models put in place and properly studied. I think whenever you look at the papers that are out there, or you try to come up to speed on the literature, I think you're often going to be confounded by the problem is that many times, particularly in the international examples, it's hard to see a single intervention which has been put in place and then studied in such a way that you know what the attributable benefit of that intervention was, whether it's waiting time care guarantees or, in this case, single-entry models. Because usually something else happens at the same time. And that something else is often a few more resources, a few more dollars, a bit more budget goes into the supply side one way or another to ramp it up, or some other intervention or perturbation takes place in the system so that it's not always easy to draw a clear line of attributable sight between the intervention, in this case a single-entry model, and a consequence of improved patient flow and reduced waiting times. In terms of Canadian examples, I think that we need to recognize and pay respect to actually the Cardiac Care Network of Ontario, long-standing, has been around now for 3 decades. It works. In certain respects, it has many of the features. In fact, it is indeed a single-entry model for cardiovascular interventions in Ontario, and it has been used over the years in many different ways to shine a bright light on the adequacy of resourcing or the appropriateness of care or what have you. And many provinces have one form or another duplicated the Cardiac Care Network of Ontario as a single-entry model. I mean, so let's be clear. We do not, across this country, not to my knowledge anywhere specifically, we don't choose who does our cardiac surgery. It comes as a consequence of a case caucus, usually after catheterization rounds, where all the available surgeons that are going to be taking up the slots in future times are part of that conference, and the cases are distributed appropriately. Next available surgeon, I guess one might reasonably call that. Other examples now are beginning to get outside of surgery. Single-entry models, certainly for joint replacement in Edmonton, we know that one has worked well, and we heard about that 2 weeks ago from Jane Squire-Howden. There's a particularly unique approach there in order to reduce the burden on the orthopedic surgeons ultimately at the end of that single-entry model. There, at the point of entry, at the point of triage, they have a rather interesting form of clinical assessment and priority setting, and a determination as to whether or not the patient does or does not need to go on to a surgeon. And that determination is made by a retired orthopedic surgeon who works in the triage clinic and who sees those patients and makes a determination of who would be a good candidates based on that clinical interaction with them to go on to have interactions with the orthopedic surgeons. And of course now the number of people that the orthopedic surgeons see in consultation that ultimately go on to the surgical event has substantially increased. But again, a surgical example in Newfoundland with a widely dispersed population and a limited, very limited size of rheumatologic staffing and expertise, they've developed a single entry model for referrals, particularly for acute inflammatory arthritis in Newfoundland, where patients with the highest urgency get in to see the rheumatologist more quickly. I've mentioned the emerging example of Winnipeg Regional Health Authority and for total joint replacement, and we've learned an enormous amount and have had the benefits of working with folks in both government and service delivery in Winnipeg, and we're most appreciative. That work is just coming to fruition now and finalization, and Zahid Damani's PhD will show us, I think quite convincingly, from the Winnipeg model what did happen in a definite sense, and what some of the consequences that might not have been anticipated or expected, and then translating that into perhaps recommendations or cautious notes to those that might be proceeding themselves in that manner. Here's a slide from Dr. Bohm. Eric Bohm is the lead investigator in that area, and from the joint replacement world. This is the Concordia Joint Replacement Group, and you can see in blue the waiting times before the introduction to single entry model, and in pink below that. And of course this needs to be tracked over time, and whenever you're introducing a single entry model, you will need to have a substantial measurement system to assess the consequences of your actions, and particularly the continuity of what takes place, because with any intervention, of course, you're going to, as you can see at the beginning of this graph, look how the pink line goes down very, very quickly. It's now starting to go back up. We need to look not only over time, but have various mechanisms of evaluating the consequences of what's taking place. From this and several other things then, in a more narrative way, I'd lay out these types of factors that strike our group and certainly strike me as pretty critical to the cause. If you're operating currently a single entry model and you need to ensure its sustainability, or if indeed you're merely contemplating, you have to have a clear purpose and a clear choice of service. Because I would simply say you don't need single entry models for everything. But if you have a lot of service providers, if there's a great degree of variability in the individual lineups that they all have, if people are waiting an excess period of time, if it's getting consequences both to those individuals waiting and the broader system, then maybe it is. You do have a clear purpose. But it needs to be buttressed by someone that, as with all of these sorts of things, clinical transformation requires a clinical champion, so do you have one or don't you? And is that person truly supported from the C-suite in administration or not? If you don't have the executive of your healthcare organization supporting the introduction of the single entry model, getting behind a committed clinical champion that has moral suasion with colleagues, that has a clear purpose of a problem that needs to get fixed and can be with a single entry model, those are clearly three critical elements. And then the entire team, of course, has got to be part of that championship, and as would put up with any of these critical success factor lists, communications is mission critical. Continuous measurement of what is taking place, though, is important, and here it can get tricky because depending on the service, you might want to be tracking waiting times, flows, and consequences in a variety of other services that don't necessarily even relate to the one that you are necessarily studying. So, for instance, it would probably be reasonably appropriate to assume that you'll track other surgical interventions in orthopedics if you were going to put in a single entry model for joint replacement. But would you track, if there was any, would you track some sort of continued measurement process in general surgery, neurosurgery, or some other similar place? And I guess the answer would kind of depend on the extent to which there was a shared resource over which competition could take place, and an impact in one area would have a correspondingly alternative impact in another. So continuous measurement of consequence is very, very important, and by way of simply giving feedback to the practitioners about what is or is not working. I can't stress enough the importance of maintaining patient choice. Certainly, the strongest argument you're going to get from many people when you choose to have a no preference list and the next available service provider is that you took away my ability to choose my doctor. And we could spend quite a long time on the issue of patient choice. It's a very, very important subject and has many elements to it, but I would say that we've studied this in several different ways over the years, and patient choice is to be respected. But, you know, the reality is that people are prepared to reduce waiting times and switch service provision to do so. And we've looked at this in Saskatchewan, and we currently have that study that's just been completed now, where we're looking at the extent to which individuals are prepared to trade off waiting time for choice. And people are prepared to, not all, but not all, at least 2/3 of patients in a couple of places where we've studied that are prepared with the promise of reduced waiting time to switch to the next available service provider. Now, what's important when that happens as a consequence of a single entry model is perhaps to consider not forcing that as the only path. Because I can certainly, in my mind, manufacture a number of different situations where I really want to stay or really want to keep a certain service provider, and I want to maintain that choice. And I think I need the right to be able to do so. And so there has to be a recognition that some patients will indeed want to have a particular service provider, and we should work towards ensuring that that happens. I think it's a no-brainer. As an example, if I need my left hip fixed this year and I had my right hip fixed last year, and I liked the orthopedic surgeon last year, I'm going to want to pick the same one this year. I'm not talking about examples like that. They're often more subtle than that. And sometimes a strong communication and educational program will lessen individuals' choice to stay in single lineups, particularly if those lineups are excessively long. But I think individuals need to be made aware. Should you choose to stay in the lineup for Dr. Samus, who is the best at hip replacement, then regrettably you will be waiting a lot longer than if you take the next available surgeon, and in this case, Noseworthy will do you tomorrow. That's the way I think we need to think about maintaining patient choice. And I would also say that that might apply, at least at startup, to physician involvement. This risks a little chaos, of course, if you have a number of physicians who simply don't wish to play in a single entry model. But as we have seen elsewhere and in Winnipeg, by way of example, that not everybody will be equally committed at the beginning. And so the ability for a particular service provider to continue to operate their lineup, I think, has to be given some level of tolerance, although I would simply submit that with the passage of time, if people really, really are waiting for excessive lengths of time, and particularly if the system is taking a bad rap as a consequence, and I think that maybe the voluntary nature of involvement and the choice components of involvement need to be tempered with common sense. Consequences, well, you know, the things you were expecting. Did the flow improve or didn't it? That's a measurable issue. Did the waiting times decrease or didn't they? And that's a measurable issue. Remember, sometimes you increase the flow, the waiting times don't go down because the demand went up on the front end. What was the degree of participation? Did most of the patients were they willing to go through it, or not? If not, why not? And what was the degree of involvement of the physicians? Were they all involved or not? And what was the consequences of those that were not? the other service provisions affected, adversely, positively, or otherwise. And of course, in the end, PREMs, PROMs, where the patient's expectations actually met with the process that you had put in place. Certainly, in places where these have become commonplace, in the OECD, New Zealand, and so on, you never hear anything about people being dissatisfied about not getting to see their own physicians. Of course, all of these other countries tend to have about a 5 to 10% of their service deliveries on the private side. So some patients actually do have their expectations met by going to the private service delivery. But by and large, patients are satisfied to deal with pool lists, and I think that we would agree that from our own experience in Canada that the Cardiac Care Network of Ontario has shown the way, and I'm not aware of people being particularly concerned that they don't have choice of the specific service providers in cardiac interventions. Final thoughts then on access in a general sense. Remind ourselves, access continues to be the Achilles heel of our healthcare system, no question. Regardless of how good it is once you get in, if you can't get in, that's a very strong message to the public that we've got a problem with the system. And let's remind ourselves that really the only reason why you make people wait a long period of time is because you're rationing services. You're constraining access, rationing services, and sometimes we do it in a very explicit way, and sometimes we do it more implicitly by long delays in service provision. Whenever you make people wait, there are consequences and there are costs, more or less, depending on what we make them wait for, and it's never a pleasant experience. But on the other hand, be careful. I don't think we should ever set up a system so you get what you want right away. I think that's perhaps true for life in general, maybe, but rapid access is not always a good thing in healthcare. There is, particularly for scheduled services, there is a lot to be said for a period of what I might call sober second thought. The notion of preparedness, the notion of readiness for scheduled services is something that we've looked at quite a bit in the last year or two as it relates to joint replacement, particularly Dr. Connor Spady's work. What is the issue for patients once they go to a clinician and there's an exchange that says you'd be better off with, for instance, a joint replacement than without one? That's the clinical interpretation of appropriateness. What then happens in the mind of the patient that gives them a sense that they are now prepared and ready for that service? And I think that rapid access sometimes challenges that. We can simply say that access could be improved in Canada, and single-entry models is one way to do it. And here's a little checklist that came from the Cardiac Care Network of Ontario, and I thank Corey Kinsbury for leaving it with us from that network. And just a checklist, you go down through that list, as many of those same things I've already said in one way or another. In this case, it has a specific governance structure because for the whole province of Ontario, often it'll be the governance within your own system. But I think that's a neat little checklist, and I thank Corey for my ability to be able to use this for you. And my last slide and my final thought on single-entry models, look, these are not a holy grail, but they certainly have been shown in many different places to increase the flow and reduce waiting times for service provision. They're not necessary for certain things. They may not even be used for certain things, so select your examples and your purpose, and know that clearly before you start. Make sure there's an alignment between the clinical champion and the senior level of support in the C-suite. Make sure about patient choice. I think as the system gets better and more mature, most people will start flowing through the usual gates, but I think particularly at the outset that retaining patient choice, and maybe one could argue for similar basis, voluntary relationship with physicians might be important. And finally, keep the measurement system going. It's the only way that you can give feedback as to what is or isn't happening, and the only way of monitoring your success and giving you a sense for what alterations you might need to make. Because there will always be unintended consequences. And you can't always measure what you don't know you need to be measuring. All said, thanks very much today, and be open for questions.
Dr. Noseworthy, thank you very much for an excellent presentation. We do have a couple of questions, actually both by the same person, Maurizio at Vitalité Health Network in New Brunswick, and I'll read you the first one. And they're related, really. So he's looking to find out the best option for a single entry point for patients with diverse conditions who show up mainly at hospital. So to what extent has there been that kind of bank lineup approach taken at hospitals?
In a general sense, I'm not aware of it happening that way, although, of course, the usual ways they show up at hospitals, particularly after hours, is they're triaging in the emergency department. But in terms of general service provision across the full case mix, one model that sorts and sifts the patient through a single entry, no. I think there would be impracticalities to that. But shifting nonetheless to primary care at a more regional level, if I might comment there, I think access to primary care at a regional level can often be improved by simply understanding the nature of the patients that are coming into your system, which ones are more urgent than others, how many slots one would need to keep open to have a flexible system to permit walk-ins for urgents and what have you. It relates to scheduled services. You would pay attention to both demand and supply side principles in doing so. But most of what I've attempted to talk about today is people that are waiting in a lineup for some sort of service provision to follow, although it can equally apply to seeing a particular type of physician or care provider as well.
Great. Okay, thank you. Another question here is, you talked about the importance of patient choice and keeping that in the forefront of our thinking as we think about SEMs. In those countries where this has become the standard practice, how has that been managed?
I can't give you data response on this. In my discussions with Ray Naden, who currently is at McMaster and has worked in New Zealand all of his life as an internist, people are quite preoccupied about the length of time that they're waiting for their service provision in New Zealand. They do not appear to be preoccupied in the least about who's actually going to provide that service. So it would appear that with the passage of time, and this is extrapolating a bit from my perspective, I think that when one gets into what I would say steady state in the single entry model, where it's the standard mechanism of service provision, and the alternates are truly an exception to the usual, it starts to lessen, particularly when people see the potential benefit of getting in faster. I do think that this does set up a strong requirement to deal with one issue that the public keep telling us is on their mind in the single entry model, and that's the issue of the reputation of the individual that's going to provide the next available service. How good are they? Am I getting the surgeon du jour? Am I getting the best available person? I think we have to be mindful of the fact that there is a concern, perhaps not a very deep one, that the single entry model does not give individuals the opportunity to pick the best available clinician for the undertaking. But quite frankly, the mechanisms whereby that's done now and the data that people use to make those choices are actually really quite often informal, colloquial, or otherwise. And the basis upon which patients really have sound information to judge the quality and the reputation of their service providers is, pretty bad or non-existent. And indeed, if we go closer to home then, and the long-standing model in Ontario, it works and people don't question it. So I just assume, Stephen, that with the passage of time and the maturity of a single entry model, that matters of this sort would tend to dissipate.
Right. I had a related question, and you started to get at it, and that was, in those countries where this has become more the standard practice, is there a correlation between that availability of data at either the facility or provider level that looks at volumes and outcomes? And do patients in those countries tend to be using that data so they can see what the pool is doing, at least?
I honestly can't answer that and wouldn't have a frame of reference to know if the patients are using it or not. What I would say, and it doesn't really answer the question, is that my sense of the developing system in the UK is you go into the system and have service provider du jour through single entry models, or you simply go to the person that you pay directly in the private system and have service provision there. So for most service provision, they simply accept the way that it's done inside the publicly funded system, and the publicly funded system, by and large, offers single-entry models and pooled service delivery.
Right.
If you want
And again,
something which might be seen to be individualized care from a named individual, you tend to have to vote for it privately.
Mm-hmm. Exactly. Interesting. Another question I would have for you is, we've talked about what's important to patients here. What have you heard, at least even in the Canadian context, but perhaps drawing on international experience, what are some of the provider concerns?
Well, important that you should raise it, because there's the groups of providers that actually provide the service, and then there's those people that refer in to get that service provided. So that's kind of the primary care world that refers in. Again, not a robust analysis completed thus far, but Zaid Damani's done work with primary care physicians to get a sense of this, and there is a level of acceptance in primary care providers for single-entry models if indeed the patients flow through faster and the waiting times are reduced. So there seems to be, in terms of pushing the patients into the system through the referral mechanism, those people seem to be reasonably accepting of single-entry models. I think you're really referring, though, to the service provider, whether it's the ophthalmologist doing the cataracts or the orthopedic surgeon doing the hips, or it's the rheumatologist seeing the arthritis patients. What do you hear from those individuals? There is a willingness for service providers to accept single-entry models. I think, like anything else, it requires change in clinical service provision, and that type of uncertainty can cause problems. It's got to be well managed, well communicated, and frankly, there's got to be a clear and convincing reason why you put the single-entry model in the first place. In other words, if the lineups are not really that long and the people are not really waiting that much, and the service providers simply don't get along with each other, et cetera, then that is not fertile ground for single-entry models. But if there's excessive waiting times with variability by weight, a lot of public attention being drawn to it, and consequences being suffered, then that's very fertile ground. Now there you can get, the burning platform might exist for the specialists. I think people often ask the correlation question is, does the way you pay the physicians matter? And I'm sure it does, although we didn't find that in Winnipeg. I think you can pool service delivery as long as it's fair, and as long as those service providers get an equal shot at providing services to that no preference list. I think that you can get people to agree. But if it's done poorly, let me put a more negative view of this. My waiting list, if I'm a business person, is my accounts receivable. And if you mess up with that, you're messing up my business. And so I kind of am not going to go along with that unless I know that the patients would be better off and I'm no worse off myself. And that's perhaps crudely put, but I think it gets often to the heart of the matter.
Great, thank you. And we have one final question here. Considering the cost of implementation versus return on investment in soft savings or otherwise, do you have any sense that the return justifies the work on the front end, since it does from a patient perspective, but wanting to take a moment to consider the financial side?
Ooh, that's an interesting question. I suppose I'll put a caveat on it. If you had been paid by activity-based funding and the volume of service and throughput really mattered to you, this would be a winner. If you're on a fixed budget, sometimes you might not feel that it's a winner to improve flow and decrease waiting times. So I guess it kind of really, there's an it depends response to that. I'd leave it at that.
Great, thank you. We're going to have to end the call there. Just before we go today, I'd like to invite all the participants on today's call to check out the upcoming webinars that we have. The next one being on May 27th, Connecting the Dots, Social Network Analysis as a Quality Improvement Measurement Tool, which will feature Dr. Thomas Valente, a professor from the Institute for Preventive Research at the Keck School of Medicine at the University of Southern California, really talking about how to use social network analysis effectively to measure collaboration. And we also have the final two webinars coming up in our chronic care series that you see on the screen.